Okay, good evening. Salam alaikum to each and every one of you, and a hearty welcome to all of you for this short webinar. At the outset, let us congratulate Professor Abdul Basit for organizing this very important webinar. And of course, it's my pleasure to welcome Professor Mohammad Atta, who is also one of the distinguished speakers for today's webinar. As all of us know, this COVID, in so many ways it has disturbed us and troubled us. But one of the things that has become positive is our online meeting. Previously we are not very familiar with these online meetings, and now thanks to COVID, our technology has been almost improved remarkably, and we are able to communicate very well. So I think we should do more and more of these online webinars, which are of importance, and especially as doctors, as health science professionals, one of the things we have to take care is there's a lot of fear, a lot of uncertainties, and moreover a lot of misconceptions. I think this is where I'm worried. I think there's so many experts coming out with so many different things and adding confusion instead of sorting out the confusion or instead of clearing. I'm very sure today's two speakers, Professor Basit and Professor Mohammed, I'm very sure they will clarify several doubts and whatever fear and misconceptions with this relationship between COVID-19 and the kidney. So thanks for giving the opportunity, and once again, congratulations to Basit, and hearty welcome to all the delegates. Yes, over to Abdul Basit. Thank you.
Our webinar today is covering a very important topic happening during this pandemic, which is acute kidney injury in relation to COVID-19. So this two talk about almost two parts. My part, I will speak about the epidemiology. First definition, because we have a good deal of non-nephrologists, and then epidemiology, and then pathophysiology. I will focus about the pathophysiology because I will explain the mechanism of tissue injury which affect every organ, including the kidney. And I will touch the treatment for two questions I received from my colleague in Sharjah about the use of ACE inhibitor and ERBs, and also the early use of CRRT. Just a rapid answer about a recent study. However, the main bulk of using dialysis or CRRT and any other aspect of treatment will be presented by my friend and colleague more than 30 years ago, Professor Atta from Johns Hopkins. So this is the outline of my talk, definition of acute kidney injury, because we have non-nephrologists, epidemiology in different high COVID-19 infected zones, Wuhan, UK, and United States, and meta-analysis, pathophysiology, and I will touch rapidly the management. I cannot go through everything. So based on the definition, if you go to the publication if you go to the literature about acute kidney injury in the last 3 decades, you will find the prevalence and the incidence of acute kidney injury between 0.5% up to 50%. And this is not the actual prevalence or incidence, it depends on the definition. So everyone is defining and making his study. Until 2004, a group of consensus of nephrologists and intensivists come by rifle classification try to unify the definition of AKI. And this rifle classification, after 10 years until 2014, they found out is not practical to apply on everywhere, and it's just for research interest. So everyone went back to the KDOQI guideline definition of AKI in 2012. And this definition is increase in serum creatinine by 0.3 milligram per deciliter or within 24 hours, or increase in serum creatinine to 1.5 times the baseline, and this apply for those who have a chronic kidney disease or more. Yeah, so we after failure of the rifle classification in 2014, everyone went back to KDIGO guideline definition of AKI 2012, which is either increase in serum creatinine by 0.3 milligram per deciliter within 24 hours, or increase in serum creatinine to 1.5 times the baseline, and this is good for those who have already CKD, or decrease urine output less than 0.5 milli per kg per hour for 6 hours. And then it has been divided into stages, actually. Stage 1, stage 2, and 3. It can show up in the screen here. Stage 1, it is 0.3 milligram per deciliter, or 1.5 to 1 times the baseline. Urine less than 0.5 milli per kg for 6 hours. Stage 2, 2 to 3 times baseline, and urine less than half milli per kg for 12 hours. And stage 3, you have serum creatinine 3 times above the baseline, and almost the patient is anuric. So this is the definition of AKI, acute kidney injury, was adopted in all of the study now, and has been adopted in the study of the pandemic of COVID-19. So this is about the definition, and the studies that I will show in the epidemiology have been adopted this definition of AKI by KDIGO guideline. And we go to the first presentation about acute kidney injury, and this is the most cited publication, and the coming of Wuhan, over 700 patients, and you will find 14% have elevated serum creatinine, 13% have elevated blood urea nitrogen, and 13% have a low GFR less than 60, proteinuria almost 40%, hematuria 1/4 of the patient, and the final definition of acute kidney injury of 5%. So if the patient have a proteinuria, hematuria, this is categorized him as having renal injury, and this was accepted almost 1 week before declaring the COVID-19 as a pandemic. And you go also, as we say always, a pathologic organ as more susceptible to injurious agent compared to a healthy organ. So if you have a patient who have a healthy kidney when they are affected by COVID-19, they need at least 5 days to start to see acute kidney injury. But if the patient on the basal have some degree of kidney injury, on the first day of infection, he starts to have affection of the kidney. So this shows the difference between healthy kidney and the diseased kidney at the start, and we call it acute in top of chronic kidney injury. This is the first study, represents the Chinese population. And this is also, they divided it by mortality. And as you can see here, acute kidney injury per se is associated with elevated mortality in those people who have a COVID-19. Are you receiving me? I'm okay?
Yeah. Yes, yes, sir. Fine,
yeah.
sir. Please
okay. Rising serum creatinine, they take the cut point 133 micromole per liter compared to less than 133. It is always associated with high mortality. And if you go to hematuria and proteinuria per se, if the patient have a hematuria and proteinuria, even with still normal kidney function, presence of hematuria and proteinuria are associated with increased mortality. And this was a Chinese experience presented epidemiology. And we go to the European experience. I picked up the United Kingdom. They have intensive care national audit and the research center. Those who are following diabetes is like the United Kingdom prospective diabetes study. So they collect all data throughout the intensive care in the United Kingdom, and they pull up the result. And if you can see here, they measured the outcome by organ support. They take it the combination of the respiratory support and renal support. And they compared the people who have pneumonia due to COVID-19 and those who have non-COVID-19 pneumonia, and they almost 5,000 patients in HR. So in COVID group, if you have a basic support only, you will have a recovery almost 82%. And if you have advanced support, here's the mortality increasing to 38%. So if you have any renal support, so you have a very high mortality here, reached to 75%. If you have a renal and advanced respiratory support, only 25% recovery and the 75% mortality if you have a patient with respiratory and renal support, compared to non-COVID pneumonias when you have only 46%, and this is very significant. And also they stratified it by overweight and obesity. So I explained in a previous webinar how the obesity can affect the outcome of a COVID-19 patient. So if you have a patient overweight, you have 30%, 34% who will need CRRT or renal replacement therapy, and you have the patient between 30 and 40 BMI. So if you have a patient overweight and mild to moderate obesity, you almost have 70% of those who are overweight and obese will need renal replacement therapy. So obesity is a major risk factor for determining the acute kidney injury and the need of replacement therapy. The third group I begged for the epidemiology, one from China, one from Europe, taking United Kingdom, and one from United States. This is a very nice study, just came back up a few weeks back, and they pulled up the data from 13 academic and community hospital in New York, which was most affected in the United States, and they excluded those who have a kidney transplant, end-stage renal disease, or younger than 18 years of age, and they adopted KDOQI acute kidney injury definition. Out of 5,000 patients, they have 36% developed acute kidney injury, and the one is stratified by a stage. Stage 1, you have 46%, stage 2, 22%, and the stage 3, 31%. And overall, 14% needed renal replacement therapy. So AKI was primarily seen in COVID-19 patients with respiratory failure. Those who have a respiratory failure need ventilatory support. Almost the incidence is almost 90% on mechanical ventilation. 4 times more those who does not require ventilation. So ventilation per se increase acute kidney injury by 4-fold. And 96% or 97% of those requiring renal replacement therapy are on ventilator. So of patients who require ventilation and develop AKI, 52% of them usually have acute kidney injury in the first 24 hours after intubation. So it's very important, because there is a nice question came up here by one of my colleagues in Sharjah. Should we start renal replacement therapy once the patient ventilated, as long as we know a large percent was going to be affected by AKI? And I think Dr. Ata will answer this question. And this is the same thing. I shows you, once the patient is AKI stage 3, you have half of them, more than half of them will die. So any patient who have AKI stage 3, more than 50% will die in New York experience. So the risk factor of AKI is old age, diabetes, and I will come to this when I go to the pathophysiology about diabetes, cardiovascular disease, plaque, hypertension, need of ventilation. So the outcome in general in this study, 35% of patients died, 26% discharged, and when they send the paper for publication, they still have 39% of people still in the hospital. So conclusion of this New Yorker study is acute kidney injury occurs frequently among patients with COVID-19. It occurs early and in temporal associated, and it's associated with respiratory failure. And it is once it happens, it's associated with poor outcome. When we come to the last disease, so we have one Chinese experience, one European and United Kingdom experience, and one United States experience. We together we looked into meta-analysis. This is a meta-analysis which just published, and it included 9 studies, most of them coming from China, and one come from the USA. They included 3 studies were prospective study, and 6 studies were retrospective. And 7 studies included all the hospitalized patients, and 2 studies included only patient admitted to the ICU. As you can see here, all the study, overall, they corrected overall in this meta-analysis, overall risk of acute kidney injury in everyone hospitalized was positive at around 3%. And the need of renal replacement therapy and overall it's almost 2%. And then they focused on intensive care patients. They found overall 19% of people who are admitted to the intensive care have acute kidney injury, and only 13% out of them they will need renal replacement therapy. And this is a global variability, and it reflects still variability in reporting is the cases between 8% in Montreal and 72% in Gent in Belgium, and almost between 20 and 35% they need renal replacement therapy, and the mortality is 60 to 75%. These reflect to you, this still in the phase of collecting the data. We are lucky in this generation because we have studied medicine in book all our life. Now we are writing medicine in this era because of the pandemic COVID-19. The third point of my talk about the pathophysiology, I think it is the most important part of my talk, and because I will focus about everything related to pathophysiology. So as all of know, is the COVID-19 receptor is ACE2 in receptor. So I will start by looking for ACE2 distribution all over the body, and as you can see, it is everywhere, and we'll focus only on the lung. You can find the AC2 only 1%, very small AC2 to counter the ACE in the lung. So if the AC2 was taken by the virus, it is devastating for the lung because it will be subject to the injury of the outcome of ACE only. And then go to the heart, the concentration of ACE2 is 20 times more than the ACE. And this is what the cardiology like. This ACE2 is only discovered in the year 2000. So in the lung, the concentration of protective ACE2 is 1 to 20 ACE. In the heart, the ACE2 is 20 to 1 ACE. And in the kidney, it is 1 to 1. And in the small intestine, the concentration is almost like more than 20 to 1. This is why some of the patients come with diarrhea and nausea and vomiting. And also for obesity, the concentration of ACE2 and adipose tissue is like more than 20 to 1 compared to non-adipose tissue, to the ACE. And this is also reflected that the adipose tissue work as a reservoir for the AC2 and for the virus also. As you can see, the ACE2 is not a circulating receptor like the ACE, which is present in the tissue and the blood. It is attached to the membrane. And in order to be activated, you have the virus who have a spike protein, S1 and S2. And in order for the virus to get hooked to the ACE2, you need to the transmembrane protease SS2. So this transmembrane protease make two things. First thing, unfolding of the protein spike on the virus surface, and opening, the second thing, opening of the ACE2 receptor to be hooked. And once this combination happen, it is very strong association, cannot be shaken. Of course, like everything in the body, for each regulator, there is the counter regulator, and the counter regulator here is ADAM16, alpha disintegrin, and the metalloproteinase, and it controls the combination of ACE2 to the virus, and the balance between the transmembrane protease and the ADAM17, which is a part of the family. We know ADAM13 in hemolytic uremic syndrome. So it ends up by the combination with the virus. And this is how the combination happens. Am I doing fine? Everyone is hearing me? Okay. And look for the distribution with Western blot. You know, in Western blot, we use always as a controlling law, it's a beta-actin. And then you look here for the lung. You look for ACE2 is only like faint compared to 1 to 20. So only small amount of protective ACE2 in the lung. So if this ACE2 is taken by the virus, the ACE1 will be very, and the angiotensin will be very injurious. You will go for the heart. The heart is the opposite. ACE2 is 20 times compared to the ACE. And then you go for the kidney. Both of them are equal. This is the Western blot. And this is nice, that came in the Journal of American Society of Nephrology. And the left side panel is a healthy control, and your side, the ACE is in green, and the ACE2 in red in a healthy tissue, it is mainly tubular and a little amount only in the glomeruli here and here regarding the ACE and the ACE2. And you will couple all of them, you will find the ACE2 is protecting against the ACE and this one. When you look to the diabetic patient, you will find the ACE in the peritubular, but when you look to the ACE2, you will find it is very weak and faint compared to the healthy tissue. You would like to compare the healthy tissue to the diabetic patient, and you look to the gloom, they have ACE a lot, but there is no ACE2 on protection. And when you couple them, you will find this picture compared to this picture. And this is reflect why we use the ACE inhibitor and ARBs in treating nephropathy in diabetic. And also it reflects when diabetes are high risk to be affected by complication of COVID-19. When you go for kidney is a very opposite organ, and it is subject to injurious agent from everywhere in the body because it is a filter of everything in the body. If you have two of this hit the kidney, you will get acute kidney injury. In COVID-19, you have all of them. Only two hit of those is enough to cause acute kidney injury. You have systemic hemodynamic derangement, cause renal ischemia. You have angiotensinogen, and they cause tissue injury. You have cytokine, and we see it's cytokine storm, and this end up by endothelial damage and thrombotic microangiopathy, and you have the direct invasion. In order to go for systemic hemodynamic, with those people who have COVID-19, usually due to vomiting, diarrhea, dehydration, they come by intravascular volume depletion. So everything when before replenishing the fluid, we have to put in our mind that these people have already lung injury from the COVID-19. So you don't hurry, you have to be careful in correcting the fluid balance. Otherwise, the patient will go from you in the pulmonary edema and the ventilation. And this, as the patient have a sepsis and dehydration, he will have low cardiac output. And with sepsis and low cardiac output, you will have compartmentation due to sepsis, will lead to interstitial edema in all tissue of the body, and also to lead to micro and macro thrombosis of the organs, of the blood vessel of the organ, which will lead to compartmentation. And this will lead to increased intra-abdominal pressure, will aggravate the kidney, the deterioration of the kidney function. And on all of this, you will have a secondary bacterial infection, which will aggravate the whole picture. So the second thing which is important, and I will focus on it, angiotensinogen 2 and how can it do the tissue injury. All of us know the angiotensinogen is made in the liver, and by the renin made by the juxtaglomerular apparatus, it's converted to angiotensinogen 1. And angiotensinogen 1, in order to be converted to angiotensinogen 2, the ACE is focused in the lung. Remember, ACE process for conversion of angiotensinogen 1 to angiotensinogen 2 is localized in the lung. And thus, angiotensinogen 1 has dictapeptide, 10 amino acids. And once it is subject to ACE, ACE has the capacity only to split 2 amino acids from the angiotensinogen 2. And then you will have an octapeptide, 8 amino acid. And this octapeptide, 8 amino acid will be, this is the angiotensinogen 2. And it is harmful when it is accumulated because it can cause vasoconstriction, salt and water retention, cellular proliferation, increased radical oxygen species, fibrosis, and inflammation. However, when the angiotensinogen 2 here, you have as a counter-regulatory mechanism, you have the ACE2. ACE2 is a nice guy, and it acts only by splitting 1 amino acid. So ACE usually split 2 amino acid from the dictapeptide, and the ACE2 is split 1 amino acid from the octapeptide. Once the ACE2 is activated, they split 1 amino acid and it becomes angiotensinogen 1,7. Angiotensinogen 1,7 is a nice guy, makes the opposite vasodilatation, natriuresis, anti-proliferation, decrease oxygen species, increase nitric oxide and bradykinin, and reduce renal injury when it join its receptor mass R. So when this is the classical pathway. There is an alternative pathway like the complement. So when you have the angiotensinogen 1, which is dictapeptide acted upon by ACE2, Then, as I said, the ACE2 capacity is to remove only one amino acid. So it will convert the angiotensinogen 1 to angiotensinogen 1,9. Angiotensinogen 1,9 again will be the subject of ACE, and the ACE has its capacity to split two amino acid. So ACE also has the capacity to convert angiotensinogen 1,9 to angiotensinogen 1,7. So we have the angiotensinogen 2, which is harmful, and then you have the counter-regulatory angiotensinogen 1,7, which have a classical pathway and alternative pathway. So here what happened is, when the virus came to the lung, you have in the alveoli two types of cell. Type 2 alveolar cell, and this is the most important cell in the function of the alveoli because it secretes a surfactant which keeps the alveoli patent and open and full of air. And you have type 1 alveolar cell, which is poor cell. It doesn't have much organelle rich as type 2 alveolar cell, which has a nucleus, Golgi apparatus, endoplasmic reticulum, ribosome. Virus like these cells because it uses its machinery to reproduce himself. In the other side, in the alveoli, you have the macrophage, you have TIL-like receptor, and it can engulf the virus and to present it as an antigen and activate immune system. And the balance between the immune system represented by macrophage and the alveolar 2, this will end up by the outcome of this patient. When the virus uses the type 2 alveolar cell and use it for producing its himself, what happened is there is no more secretion of surfactant, so the alveoli collapse. There is no more air inside the alveoli. It induces atelectasis and no more air, and this will be responsible, and the alveoli will collapse, and this will be responsible for the ground glass appearance in the X-ray. And then finally, this virus will shed in the pulmonary capillary and the anterior side, and it will go to the whole body. What happened here happened exactly inside the kidney when the virus go outside and then go to the endothelial cell in the renal capillary, and you go to the podocyte, which is a rich machinery cell like type 2 alveolar cell, and the visceral epithelial cell, and then go to the mesangial cell, which is a rich cell in ACE2. So you have the endothelium, you have the visceral epithelial cell podocyte, and you have the mesangial cell. All this will be affected by the virus, and again also the tubular surface, the brush border of the tubules, mainly the proximal convoluted tubule. So as the virus affects the type 2 alveolar cells and decreases the secretion of surfactant, causing collapse of the alveoli and the ground glass appearance, it affects the endothelial cell, podocyte, and the mesangial epithelial cell and the brush border of the cell, and they end up by a series of renal lesion. And this is will summarize this just come so when the virus joins the AC2 on the surface of the cells, it depletes the AC2 by taking it into cytosis inside the cell. When it depletes the AC2, which is responsible for formation of angiotensin 1,7 and angiotensin 1,9, when you deplete the AC2, you will leave the organ are subject to the massive destruction by angiotensinogen 2, which is produced by the ACE. So this is the story of angiotensin 2. If you have these two insults with enough to cause acute kidney injury, and this will activate complement. Then we'll go to the cytokine. Again, the same thing. You have, I will not go in detail. This is the macrophage. It has a TIL receptor, and it takes the cellular debris. It causes antigen processing presented through the major histocompatibility complex to the T lymphocyte. So it activates the T lymphocyte to produce interleukin 1, interleukin 6, TNF alpha, and the interferon gamma. Reciprocally, after signal 1 and signal 2, T cell also activate the macrophage to produce again interleukin 1, interferon gamma, and the interleukin 6. T cell also can activate the B cell to produce the same panel of cytokine. B cell itself has 3 functions. It can act as an antigen presenting cell and stimulate the T cell. It can be stimulated by the T helper cell and produce cytokine and antibody. And it can be stimulated directly by the super antigen, by the antigen itself, we call it super antigen, and become machinery by itself without even connecting it to the T helper cell. And you go here, IL-1 is responsible for fever, TNF alpha is responsible for the vascular endothelial damage, and the IL-6 maintain both IL-1 and the TNF alpha to produce its effect. So when the cytokine happens, this causes inflammation, and it might lead also to rhabdomyolysis, one of the mechanisms of rhabdomyolysis. And all this together, when they collect together and come to the endothelium, it causes endothelial injury, and finally you have the direct antigen. So you end up by organ crosstalk. You have the virus affecting the lung, affecting the heart, affecting the kidney. Once the lung is affected, you have pneumonia, you have thrombosis, you have hypoxia. And once you have hypoxia, you have medullary hypoxia. Medullary hypoxia decreases the function of the kidney and lead to salt underwater retention. And the salt underwater retention will cause congestion in a visual circuit. You have also the virus can directly affect the heart, cause myocarditis, suppression of myocardial activity, decrease the cardiac output, cause hypoperfusion of the kidney, aggravate the kidney function. And also we have renal compartmentation from sepsis due to interstitial edema and micro and macro thrombosis. And all of this lead to systolic dysfunction. So you have the dilemma, each one is talking to each other, and also you end up by direct virus invasion to the kidney. So all this organ talk will lead to affection of the lung, affection of the kidney, affection of the heart. And this is show you as a proximal convoluted tubule, it have a vacuolization. If we go to the electron microscopy, this is the virus inside the vacuole. This is the virus with its speculation on the surface in the proximal convoluted tubule with its spike. And you can look here, it is again a lot of virus in the proximal convoluted tubule. The other side is the collapsing glomerulopathy. When actually this is not specific for COVID-19, it's for every virus, HIV, HCV, where you have the virus here, have a direct invasion. And you have the podocyte here, and you have the virus with its spike inside it, and you can see it more here. This is the virus, more magnification. You can see the virus inside the podocyte. So this is the pathophysiology. I will touch the management before I give the talk to Professor Atta. So management of patient with acute kidney injury and COVID-19 is a multiplicity, is a multidisciplinary action. I'm sorry for those who are thinking management of acute kidney injury is just prescribing of dialysis and then CRRT. This is, for example, myself, I made the CRRT is a standard of care in the Ministry of Health. And I made a standard order for all the first on-call general practitioner to do the prescription. But you have to track all of these items while you are managing the patient with acute kidney injury. You have to think about everything and to try to approach it. It's not only dialysis, and it's not only CRRT. And I will start by managing when you speak on a stage 1 by definition by QIDO. The first thing is fluid therapy, but you have to think is that you have a damaged lung. So you have to be careful not to induce pulmonary edema. You have a patient with sepsis, with capillary dilatation and leak. So you have to think of vasopressor to maintain the blood pressure. And you think of the antibiotic to prevent or to treat secondary sepsis. And please, when you look for antibiotic, please be careful of using those who are a nephrotoxic drug, especially aminoglycoside. And if you tend to use antifungal, please stay away from the nephrotoxic anti-amphotericin. Neither in the early stage nor on the recovery stage, because the more you cause kidney damage, as I showed before, the more the mortality of the patient. So be careful with the nephrotoxic antibiotic and the antifungal medication. Our recommendation and nephrology not to use them early, not to use them late, unless you have extremely resistant microbe or fungus who only needs this, and you need to adjust the dose. And then we'll go for a question asked to me by Dr. Muhammad Nasif, who is he's a leader actually in the COVID-19 pandemic treatment, and he's a consultant in a Qasimi hospital. What about if you use of ACE inhibitor, ARBs? And I made the introduction before, I will go rapidly through it. So here, if you use ACE inhibitor, you prevent the formation of angiotensin 2, which harms the kidney. But on the other side, you will increase the ACE, the ACE2. ACE2 will increase the affinity of the COVID-19. So it's true you block the effect of angiotensin 2, but you will increase the affinity of the virus for these people, and this could be deleterious also. And as it's true, you will increase the angiotensin 1,7, but you will increase the affinity to COVID-19 who use ACE inhibitors. This is about the ACE. And however, by blocking the ACE, you will increase bradykinin, and the bradykinin will increase the tissue plasminogen activator, and this is a beneficial effect. So you have a beneficial effect for the beneficial of blocking angiotensin II, and you have a harmful effect for increasing the affinity to the virus to affect this. So this is regarding the ACE. What about regarding the Arabus? It's the same thing. If you block the Arabus, the AT1R receptor, which is the receptor for angiotensin II, it will lead to accumulation of angiotensin II. It will lead to activation of angiotensin II receptor, and this will end by increasing ACE2 receptor also, which will increase the affinity of the virus. It will have a beneficial effect by angiotensin 1-7 through the multiplicity of effect I explained before once you join its receptor. But again, it will increase the affinity to the virus. So it is a dilemma. If you stop it, you will. If you block the ACE or ARBs, you will prevent the harmful effect, but you will increase the affinity to the virus. So this is just coming New England Journal of Medicine. So in preclinical study, suggested RAS inhibitor may increase AC2 expression, raising a concern regarding their safety in patients with COVID-19. And the other way around, abrupt withdrawal of RAS inhibitor in high-risk patients, including those who have heart failure or have myocardial infarction, might result in clinical instability and adverse effect. So the conclusion, don't stop. So if you have a patient who is using ACE inhibitor or ARBs, don't stop it. It is the same statement for statin in patient with end-stage renal disease. Don't stop. But if the patient basically didn't need ACE inhibitor or ARBs, so if you start it, you might hurt the patient more. The second point, I was asked is a question by Dr. Manar in Kuwaiti Hospital, and she has a nice question. I hope Dr. Muhammad would touch it. If we have more than 50% of people who have got ventilated develop AKI in the first 24 hours, so why we don't start absorption column or high flux column to start immediately, even before the patient show acute kidney injury based in kidney classification. And this study case came from the United States. They divide early initiation of renal replacement therapy within 12 hours after documentation of AKI, or delayed after 48 hours of documentation of AKI and no recovery occurred. So less than 12 hours versus more than 48 hours, and the outcome was delayed strategy or early strategy. There is no significant difference at the start or even at discharge of the patient. So early, which was in less than 12 hours, late, less than 12 hours from definition of acute AKI stage 1, or late maybe as a stage 3 after 48 hours, either for the outcome or at discharge, there is no difference. And there's a small touch with the patient who have of chronic patient who have a stage 1 and the stage 2, they apply all the comorbidity in general population, because those represent like 10% of working population. However, those with a stage 3 and 4, this is meta-analysis, and it can show you mortality increase by 3 to 4 times. So you have to treat them as an AKI on top of CKD with the previous thing. And you have those on dialysis. In this study, you have almost 2% in 2 months, so to almost 1% per month. So if you stay 12 months, you will have 12% dying, and the mortality is 30 to 50%. So to conclude, kidney is a subject to significant injury, and proteinuria, hematuria per se are important marker, and the AKI are a main manifestation. So even if there is no rising of the serum creatinine, you have to look for hematuria and the proteinuria and consider them. The renal pathology are heterogeneous, and I explained, in form of tubule, gloom, blood vessels, and interstitium. Kidney injury in multifactorial, including systemic hemodynamic, ACE2 balance, a massive cytokine release, endothelial injury, capillary thrombosis, multi-organ crosstalk, and finally direct viral invasion of proximal tubule and podocyte. Management must address all pathogenic factors, not just the prescription of dialysis or CRRT. ACE and ARB so far, don't start. Early versus late renal replacement therapy so far based on study, no significant. I hope that Dr. Muhammad may have more information about this. Prognosis in poor, once the patient is diagnosed as an AKI, especially those who have AKI on top of a CKD and have a multiple comorbidity. Thank you very much. And this is these days remind us we are like in a war zone, and remind myself when I was in a military college in Fayed in Egypt. So thank you very much. I will allow myself to introduce my friend, Professor Muhammad Atta, who started his working as a resident in Mansoura Urology and Nephrology Center. And currently he is a full professor in Johns Hopkins University. He's a director of many things inside the university. And he's always worked with us as a visiting professor, and he is a director of one HIV nephrology clinic, so he has a lot of experience about virus nephropathy. He is a director of one clinic in Johns Hopkins University. He is well-known, supported to International Society of Nephrology charity service in the poor country in Southeast Asia and Middle Africa. So he will speak to us about renal replacement therapy and if there is further completion of management in patients with COVID-19. Thank you. You can go.
So thanks again, Professor Abbasid, for the invite, and thank you all for attending. First of all, I have to apologize my talk, which is going to be short, hopefully. It's not going to be as scientific as Professor Abbasid. It's more about really logistics rather than science, because as you can tell, we have been learning as we go with this pandemic. So I think Professor Abbasid mentioned the incidence of acute kidney injury and CRRT around the world, and I really want to make a couple of points. One, that there is a big difference between what is reported from China and what is reported from Europe and the United States, and just lumped all the Chinese publications together to give you an idea about the incidence of AKI, which you can see here. It goes from 5 to 15%. So that's really the incidence. And if you look at how many patients required renal replacement therapy, it will go from 1 to 5%. So again, this was in China, and different provinces in China. If you go to Europe, and some of these studies were also mentioned by Professor Abbasid, in Europe and in the United States, you'll find out that the incidence of acute kidney injury, and again, here the definition of acute kidney injury differs. So for the first two studies, one in England and one in Seattle, that was the requirement of renal replacement therapy. Here it's called kidney replacement therapy. So again, it's 17 to 19%. So, and that's really what is required for renal replacement therapy. So the incidence went from 20 to 60%. So you can see here 28%. But if you look at among critically ill patients, 61% of patients developed AKI based on the KDIGO definition. And here in New York, based on stages, again, 37% of patients develop acute kidney injury. So the incidence really was much higher than what is reported in China, between 20 and 60%. If you look at the need for kidney replacement therapy, here it's 19%, because that was the definition of acute kidney injury. So 19%, 17%, 20%, 5 and 15%. So again, it goes from 5 to 20% requirement for kidney replacement therapy, or CRRT. So we think that really we had a higher incidence of both AKI and CRRT in Europe and the US. And this was mentioned before by Professor Abbasit. If you look at really the time of acute kidney injury diagnosis, you will find out at the time of intubation, that's really the bulk of patients that actually developed acute kidney injury. This is the time of initial acute kidney injury diagnosis. You can see here, most of the patients, obviously some of the patients developed before intubation, but you can see that really the majority of patients developed acute kidney injury at the time of intubation. And I think this reflects that those patients not just having hypoxia, but also requirement for vasopressors and hypotension. So it's really the initiation of what we call cytokine storm, and that's when you develop acute kidney injury as well. So this was in the lay press from different issues of the New York Times, and really reflected the logistical issues about staffing, about dialysate, about machines of dialysis, and really the shortage on all fronts. So no staffing, no machines, and also no solution to do dialysis. And this happened across the Northeast when the pandemic hit. And I can tell you that the start from March until the end of April was really a major problem in our hospital. So this is reflected also by one of the tweets by J. Radhakrishnan from Columbia in New York, which really he wrote, the dire strait in New York City, shortage of dialysis nurses, CRRT machine, and fluids across all hospitals. If you know nurses who are able to volunteer and if able to donate CRRT machine and fluids, please email me. And we helped him, by the way, I'll tell you how. So it reminded us by the 1960 when we had a committee in Seattle that actually decides who actually can get dialysis, so who lives and who dies. And this was really something that came to mind to a lot of nephrologists who witnessed this time when you have this committee deciding on the outcome of patients who are requiring dialysis. So what are the challenges with renal or kidney replacement therapy in COVID patients? Obviously, fluid balance, as mentioned by Professor Abdelbasit, and the ventilation that is positive, the beep that you use on a lot of these patients, coagulation disorder. The patients are usually prone once they are ventilated because we found that proning patients during ventilation has been helpful in really improving oxygenation. And then obviously the most important was resource utilization. So as you all know, especially nephrologists, dialysis is a limited resource. I mean, you have a number of machines that you can use. You have a number of CRRT machines that you can use. So some have shifted from normal practice to, for instance, patients who can actually tolerate hemodialysis. And instead, usually we do 3 times treatment, but for COVID patients, we actually shortened the treatment to twice weekly. We did 3 hours rather than the 4 or 5 hours that we usually do for dialysis patients. Those for end-stage kidney patients, because obviously they have normal hemodynamics. But for patients who are in the ICU, and we had a lot of them, we had to actually improvise and do other things. And one of the things that we have done, which is the prolonged intermittent renal replacement therapy, which is really high dose CRRT, but we do it for 10 hours. So instead of having the patient on CRRT for 24 hours, we can do the patients only for 10 hours and split with other patients to do another 10 hours. And then we can do it every other day rather than daily. We also employed acute start of peritoneal dialysis, except for patients who are prone, we couldn't do that. But patients who were not prone, we were able to start acute PD for those patients rather than start them on CRRT. So the other thing is that some hospitals did in New York shifted everybody to the prolonged intermittent renal replacement therapy because of the lack of the nursing, and we'll get to that. So if you look at any units on the Northeast, we usually at normal conditions we have about 15 to 20 CRRT working in the ICU. So this is on the y-axis here, the number of CRRT machines, and that's under normal conditions about 15 to 20 machine working in the ICU. But if you look, and this really reflects all the Northeast time between mid-March until the end of April, you can see that the number in black line here, the number of COVID patients that increased dramatically. And along with that, the number of requirement for CRRT increased dramatically. So we went from 20 CRRT requirement or 20 CRRT daily to over 60 CRRT daily. So this is on this axis, on the y-axis, this is the number of patients of COVID-19 positive. So you have about 200 patients in mid-April, and about a third of them requiring, about 60 patients requiring CRRT treatment. So obviously that was a lot of strain on the system. So what we did obviously sourcing supplies. So we had hospitals who were not using CRRT. We had to use their machines. We had cartridge from other places where they had less number of patients to match our plans. We did for the hemodialysis, and instead of usually we have since those COVID patients were isolated room, so we had usually one nurse per patient. So we actually hook cameras on the HD machines, and we have one nurse watching two machines rather than one nurse per machine. So this way we can actually use the staff appropriately in an economic way. And then the other crisis that we had was the fluid, the replacement fluid that is used to generate dialysis or dialysate for CVHD. And I will tell you what we did, and this was really remarkable because we used the same system with the Colombian folks to generate their dialysate as well. So so what are the dialysis alternative? Just to review quickly, so you have the alternate day CRRT, split CRRT, so you can use actually CRRT every other day than daily. You can do it for 12 hours. You can do the prolonged intermittent renal replacement therapy, and another definition is low efficiency dialysis, and that's using actually the actual dialysis machine, not the CRRT machine. And again, the acute PD was another way of overcoming resources. So if you look at the American Society of Nephrology, they have some recommendation about these type of therapy, and we use the intermittent hemodialysis policy, which is really limiting the dialysis to 3 hours and limit the dialysate flow to 600 ml instead of 800, and use twice weekly dialysis rather than the 3 times per week. Now, you can use the slit machine. Again, this is really a slow, and here you have the blood flow is about 200. The dialysate flow is 200, and you do 8 to 12 hours of treatment, and this really can be delivered every other day, and the ICU nurse can watch those patients rather than having the dialysis nurse actually monitoring those patients. The same with the prolonged intermittent renal replacement therapy. The advice here was 40 to 50 ml per kg per hour. Again, 8 to 12 hours. You can use it daily or every other day, depending on resource utilization and availability. Now, the one thing that really was a major issue was really the replacement fluid recipe, which is dialysate. And you can use this, which you can make 4 liters of dialysate using this scheme, which is 1 liter of normal saline plus TCL as needed based on the patient's serum potassium. And then you have isotonic bicarb in 1 liter of D5 water and 150 milli equivalent of sodium bicarb. You can have 1 liter of sodium chloride with 1 gram of magnesium chloride, 1 liter of sodium chloride, and 1 gram of calcium chloride. and all of this will be 4 liter, and the 4 liter will end up having 153 of sodium, 37.5 milliequivalent of bicarb, and magnesium 2.6 millimole, and calcium 2.25 millimole. That was a way of doing your own dialysate. We did a different way. We had actually our dialysis machine make the dialysate. So if you hook the patient on dialysis machine, this is a machine that has no patients. You usually have your dialysate, and you have either, I don't know if you use granulite or whatever the material you use, whether it's a fluid or bicarb cartridge. So the cartridge that we used to make the dialysate. So we had the machine, actually the dialysis machine makes the dialysate and then put it into TBN bags, and we actually culture the dialysate to make sure it's sterile, and it's actually sterile for 24 hours that can be used. So this way, the way it works, you have the dialysis machine, there's no patient involved. You just put the dialysate that we make usually for the patient. The machine usually makes that dialysis. So you hook the dialyzer, and we use the OptiFlux high flux dialyzer. And now we had a connector, and we have a biomedical engineering student actually make a connector to hook to the dialyzer and make the machine makes the dialysate and then bore it into a TBN bag. And we use that to actually for the CRRT machine. And that's what we give the same idea to Colombia to use to make their own dialysate so they don't run out of solution. The other issue that have been seen in a lot of patients is clotting, and clotting not just for organs, but also the renal replacement therapy. And as you know, frequent clotting was reported early in the pandemic, mostly with CRRT more than hemodialysis. And we know from before that we have mechanical factors like, for instance, the catheter, especially for patients who are prone, you can have the kinked catheter and so forth. Also the circuit factors. So if you have a lot of ultrafiltration, you can obviously have a high filtration fraction that actually increase the likelihood of clotting. If you're using a lot of replacement fluid, also that will increase the likelihood of clotting. But also for COVID-19 patients, we knew that there is disruption in the coagulation cascade leading to frequent clotting. And this is just one study that looked at almost 450 patients with COVID-19 and compare them to almost 200 patients with non-COVID patients, and looking at the mortality and also looking at clotting issues and anticoagulation. And what if you look at the baseline characteristic, sorry, it's 104 patients, non-COVID patients, not 200, but 450 COVID-19 patients, and you compare the age, obviously is slightly higher, 65 versus 58 years, but the other thing that was different was the platelet. Actually, platelets in COVID patients were higher, and this was a Chinese study, by the way, as well. So that was significantly different. But if you look at the D-dimer, which normally is 0.5, it was really in COVID patients the same compared to non-COVID patients. But when they looked at the 28-day mortality, as you would expect, COVID patients had twofold increased mortality compared to non-COVID patients. And then they looked at really the D-dimer and the anticoagulation. So here, this is a COVID patient group, and this is a non-COVID patient group. And here on the y-axis, the 28-day mortality, and this is all patients, no difference. But if you stratify them by the D-dimer level, once the D-dimer actually go above 3, which is 6 fold more than the upper limit of normal, you can see that the mortality of those patients who received heparin actually have higher mortality. Obviously, it doesn't tell you that heparin is the cause of higher mortality. It tells you that those patients who have higher D-dimer, six-fold from the upper limit of normal, are sicker patients and required heparin, and that's why they have higher mortality. But obviously, this is six-fold, this is eightfold, and you can see here that those patients have higher mortality if you look or you stratify them by the level of D-dimer. This was not seen in patients who were COVID negative, so there was no difference between patients who received heparin or not receiving heparin if they don't have COVID diagnosis. If you look at the autopsy and you look at the lung, this is the lung, and you can see here it's edematous, and also you can, if you take a cross section of the lung, you can see clots in the lung here, clots in the lung. If you look at the heart, again, you can see clot here. You can see the right ventricle is very dilated. The septum is straightened rather than being really concave. So definitely those patients have what we call very high risk for clotting and thrombosis. So what did we do for the anticoagulation? Obviously, you have a lot of things that you can use. The worst one is the pre-filter saline, didn't make a big difference. So anticoagulation was really the one thing that you have to do with all CRRT patients for the most part, unless it's really contraindicated. So you have the heparin, whether it's systemic or regional. So systemic usually for patients who required ECMO, because ECMO patients already on systemic heparin, so we didn't have to do regional or anything. So we used this as a primary source of anticoagulation. We used low molecular heparin if we need to. The other thing that really what is recommended by the KDOGI is using regional citrate anticoagulation. And if you ask me, it is the best anticoagulation for CRRT machines. The problem is generally really it requires intense follow-up by the nursing staff. So you have to balance between really the intense workload that is needed when you have patients on regional citrate anticoagulation and between really the clotting issues for these patients. And then you have obviously the direct anticoagulation, and we used quite a bit of those for those patients. This is a review from 2014 about the advantage and disadvantage of different anticoagulation strategy. Obviously, heparin, everybody's aware of it and everybody have used it. So you know a lot about it, and has short half-life. You can reverse it quickly and you can monitor patients very nicely. Problem with it is really unpredictable and also hit, which can happen, and a lot of our patients actually have hit for some reason or another. The other thing is low molecular weight heparin. It's more reliable and reduce the risk of hit. The problem is cumulative effect and expensive, and also you have to monitor factor 10 or activated factor 10 while those patients are receiving low molecular weight heparin. Citrate, as I told you, it's my favorite, but it requires intense monitoring. It can cause metabolic acidosis and hypocalcemia. Those patients require IV calcium away from the circuit, and you have to monitor their calcium. We prefer every hour. Some centers do it every 2 hours, but really you have to be very careful, and you cannot use it in liver patients. If the patient has liver failure, or you cannot obviously use it because citrate is converted to alkaline by the liver or bicarb. So you have the risk of metabolic alkalosis if you have a good liver, obviously, but you have to monitor for these things, and hypernatremia is another potential risk. And then you have the direct anticoagulation products that you can use, safe and effective. The cost is a major issue for a lot of folks, and also lack of experience in most centers is another thing. So, and I think Professor Abbasit mentioned about the layers of acute kidney injury and why some patients develop acute kidney injury, why some patients actually require ventilation, and why all of this happened. And this is a nice study that is from China, and really he looked at over 994 patients from Shanghai and compared them to 220 patients from other areas. And he looked at this is the SARS-CoV-2, and basically he looked at really the phylogenetic or the genetic makeup of this virus in Shanghai. And Shanghai, for those who don't know how far is it from Wuhan, it's about 800 kilo from Wuhan. And when they looked at the genetic sequence of those 94 individuals from Shanghai, they found actually they have different virus compared to the one from Wuhan. So this, they call it clade 1, which is, there are different, mainly at position 84 of the viral sequence. So there is a couple of amino acid. One is leucine and the other serine. So clade 1 has leucine, and clade 2 is serine amino acid instead of leucine. So they found that really this started, the Wuhan clade 1 started in the seafood wholesale market in that province, and the clade 2, which is really not linked to the market, which has serine amino acid at position 84 of the sequence. And so the thought is that probably those two types of viruses happen at the same time, but not at the same place. And you have a group of patients who develop asymptomatic, or the asymptomatic group, and those you can actually look at their blood count, for instance, and you'll find that their lymphocytes are okay. So those are patients who have no lymphopenia, and that's really a marker of disease activity. And also they don't have a lot of IL-6 or IL-8 cytokine release, and they don't develop these cytokine storm. But then you have those patients, the critical group, who actually have lymphopenia, and we measure the severity of disease. If you don't have CRP, or I'm sure everybody has CRP, but if you don't measure IL-6, for instance, and you don't want to do it, you can look at the lymphocytes, and lymphopenia is really a good marker, and the severity of lymphopenia is a good marker for disease progression as well, and it coincides or matches the amount of cytokine release in those patients. So you can have a high IL-6 and high IL-8 as well as a marker for disease severity. So this is important because not everybody requires treatment with anti-cytokine or anti-cytokine therapy. I think if we monitor patients with cell count and really other marker of inflammation, we can decide who should be treated with these agents. So the issue of cytokine release and the cytokine storm triggered a lot of interest in using some of the stuff that we have used in CAR-T therapy with the macrophages releasing all these interleukin-6, and there is already approved drugs for interleukin-6 receptor, which is tocilizumab. And the first was a case report of using tocilizumab in patients with COVID-19 who have high inflammatory markers, and that was published recently. And then followed by 21 patients treated, all of them treated with tocilizumab as well in China. That was also published recently. And if you look here at the CRP, and this is before, so they have data on 20 patients here, data on 21 patients. Those are the 20 patients. If you look at the CRP, and the CRP here, you can see the numbers before, and you can see that some of patients probably didn't require to be on tocilizumab. But for those who have a very high CRP, especially those above 100, you can see the measure in 5 days. A lot of them had recovered CRB or the inflammatory response that we see in these patients. Fever also was high before starting the tocilizumab, and again, by 5 days, everybody was febrile. So again, this triggered a lot of interest in treating some patients, not all of them, obviously, with anti-interleukin therapy. So if you look, and this was from yesterday, I pulled some of the clinicaltrials.gov, looking at all the studies that looking for intervention for COVID patients. And you can see here that the tocilizumab is used. We have at Johns Hopkins, we have, so tocilizumab affect or inhibit the receptor, the interleukin 6 receptor. So you have to be careful, because if you use tocilizumab, the interleukin 6 will go up because you are blocking the receptor. We have the other product, which is anti-interleukin 6 itself, which is the clazakizumab, which is really, we enrolled already 30 patients, and this you use 25 milligram intravenous once. And basically this will inhibit interleukin itself, so it will lower interleukin level, and this is versus placebo. And then you have also Cedars-Sinai using the same product. You can see here 25 milligram in New York, and also different dose, 12.5 versus placebo. And then there is also other anti-interleukin drugs that have been tested or being tested right now. The Ankenra, which is anti-interleukin 1, is being used. We use the Ankenra in a lot of hemophagocytic syndrome patients, and this will require a daily sub-Q injection, 100 milligram. So some patients you can use so they want to use, basically you want to use interleukin 1 and anti-interleukin 6, so in combination basically, versus the usual care. So this is a European study that is being done in Belgium, multi-center. And then the other thing that really came to mind, and also have been in the press lately, which is using the cytosorb adsorber, which have been tested to as a blood purification dialyzer to remove all these cytokines. And the company is in New Jersey, and this product is already approved in Europe. So the first data came from actually China, using a similar dialyzer to absorb all these cytokines and show that it's helpful. But then now there is a big study in Germany, not a big like phase 2 trial, using this cytosorb adsorber in patients with COVID-19. Just want to give you an idea. So the cytosorb is really a filter, a regular filter that you actually put. So this is your dialysis machine, and you have your dialyzer. The arterial, so the blood basically go to the cytosorb dialyzer. So they are parallel right here, and then it goes to the pump, and basically it turns to the patient. It goes back to the patient. So it's really trying to get all the cytokines absorbed to this column, and the column is made of these beads, and the size, each bead is the size of a grain of salt, and each bead will work like a sponge that actually stick all these big molecules to it, and probably make those cytokines go down. I just have to remind you that purification technology has been around for a long time, and there have been a lot of attempts to basically use it in septic patients, and without success. So I don't want you to be on the height of hope about these products, but I can tell you that if you go to the website of the company itself, the cytosorb, if you look at really the literature database, you'll find out that all the literature database is about case reports. So a case report of 45-year-old man This is a German study that has been done now, but it's not out yet, obviously. And then this is another case. And if you go down, you'll find many cases. So it's really all based on case reports so far. The Cyto risk study, the German study that is really looking at the structured way of looking at patients' outcome based on data rather than just case studies. And again, they are including 7 ICU units in Germany, or 7 centers with 10 ICUs. And you can look at the requirement. So you have a COVID patient that is positive, C-reactive protein more than 100. So that's a requirement. As you know, procalcitonin is usually low in COVID patients, so it has to be less than 2. And then a suspected cytokine storm, which is defined by a requirement for pressors, norepinephrine more than 0.2 microgram per minute per kg to achieve mean arterial pressure above 65. Now, you don't have to actually require, and that was your question, you don't have to require renal replacement therapy. So you don't have to be actually in acute kidney injury to use this to be in the trial. You only need to be COVID positive. You have evidence of inflammation as required by C-reactive protein, and really in shock requiring pressors, but also you have to avoid patients who have proven bacterial cause of the shock. So those are contraindicated. And they are planning to enroll 80 to 100 patients, 40 to 50 patients per arm. And obviously this is currently ongoing, so there is no data yet. On April 10, 2020, the FDA in the United States actually authorized the emergency use of this CytoSorb. As you know, that we have the FDA is working on anything that may help. And again, its indication is really for COVID patients, emergency use only. So it's not really approved for everybody with COVID patients. And really, the one thing that you have to know, that you have to use 2 dialyzer. Each dialyzer is $500. So for the first day, you need $1,000 for the dialyzer, just for the dialyzer, not for anything else. And then you have to change it after 24 and after 48 hours. So basically, in 3 days, you will require 4 dialyzers for 1 patient, and that's really important to know. The blood flow is recommended is 150 to 500 ml per minute for these patients. And then after 72 hours of treatment, you have to determine if the patient had any clinical benefit of continuation or not. So that's really the key issue. Now, you have to be aware, if you're going to use this dialyzer, you cannot use it in patients with thrombocytopenia, platelets less than 20,000. Obviously, if you have any contraindication or allergy, or even if you have a history of heparin-induced thrombocytopenia, because those patients will require anticoagulation as well. Can't use it in sickle cell patients, and morbid obesity is a contraindication as well, over 40. I think the issue is going to be really a lot of these dialyzers are likely to clot, and you're going to use a lot of them. So they are trying to limit the number of dialyzers used per patients to maximum of 4, rather than just change dialyzer on a regular basis. And if you expect that the life expectancy, any medical issue, like if the patient has cancer, for instance, a terminal cancer, you are not supposed to use it if treatment is deemed clinically futile. And that's obviously a relative term that can be decided between the patient, family, and primary physician, or the physician doing this type of treatment. And pregnancy is contraindication because it hasn't been tested in pregnant woman. Now, the other thing that is really relatively also contraindicated is the use of immunosuppressive medication. So if the patient is immunosuppressed, or concomitant use of corticosteroid, these are not absolute contraindication, but again, it's mentioned as well. So the options for AKI, if you're going to use IHD, obviously shorten treatment, the frequency and duration, and there is no data, and Dr. Abbasit also pointed out to this, there's no data to support early initiation of renal replacement therapy in COVID-19 patients, so you cannot really say, well, let's start, but I wouldn't, also I would be careful with giving the patients a lot of fluid, especially with their pulmonary status at risk. So we try to delay as long as we can, starting patients on renal replacement therapy. Obviously, CRRT is recommended for severe patients, with especially those with ARDS. And the other thing that I mentioned, that the prolonged intermittent renal replacement therapy, which is a hybrid treatment that can be used to provide intermittent, but also using a regular machine rather than the CRRT machine. If you are short on supply, you can do 8 to 12 hours, and you can do it every day rather than daily. So again, this is really for places where CRRT is not available. You can use prolonged intermittent renal replacement therapy because it optimizes the dialysis nurse's time. They can actually do multiple patients at the same time, and one nurse can watch them as well. You will need anticoagulation, as I said before, and the data on cytosport is still pending, so stay tuned about this. So I'm going to stop here, and I'll be happy to answer questions.
Thank you very much, Professor Ata, for this fascinating lecture for nephrologists and intensivists more than the general audience. We have learned two great things we can help. First one is to make our own dialysate fluid, because we have crisis. I have the people from the company came last week hunting for dialysis fluid, because everyone is asking and it's short. And the second thing, prolonged intermittent renal replacement therapy, which will avoid us from the shortage of the CRRT machine. These two strategies, we can make our own dialysate, prolonged intermittent renal replacement therapy using the hemodialysis machine. This will be saving for us, can help our practice in this area of the region.
Absolutely, and especially that you can actually use also the regular dialysis machine to do that type of treatment. You don't need CRRT machine.
Yeah, and also thank you for highlighting the cytosorb and immunoadsorption machine, and I will start a question about it. Is this immunoadsorption is only taking the harmful cytokine, because there is some beneficial cytokine like IL-10 and IL-4 which balance this harmful cytokine.
Right. So. No, it's not selective, and that's why I say you have to wait for the results, because our data on sepsis and really all these purification methods has been unsuccessful. So if you have a cytosorb dialyzer, it's not going to be selective for IL-6 and IL-1. It's going to remove everything. So you have to be aware of that, and that's why I think we shouldn't be jumping on using this type of system until we have enough data to utilize it.
Okay, so the floor is open for question. Anyone have questions?
Yeah, there are a couple of questions which have come up. One is from Dr. Mohammed Nasir. He wants to know there has been a relation between the use of ventilators and increased risk of AKI in COVID patients, and this has been published. Any explanation for this?
Well, as I mentioned, that really the idea that patients who are on the vent support are also developing acute kidney injury, it's really a reflection of overall patient status, meaning that those patients are the ones who are requiring pressure support. So yeah, they are already in shock. So, and you have cytokine release already. And that's why sometimes we start treatment when we feel that the patient actually is close to being intubated. That's when the time to decide whether you want to use anti-cytokine treatment or not, because you don't want to wait until they actually get intubated. So if you think that they are on the verge of cytokine storm, that's the time when you know that everything is going south, And that's really when they're gonna develop acute kidney injury as part of multi-organ failure. It's not just unique to the kidney. And I think it's just a reflection of overall morbidity rather than really a specific to the ventilation itself. It means that those patients are doing worse and they are developing a multi-organ failure.
Okay, there's a question from Dr. Subhranshu about cytokine storm and its relation to AKI. What could be the mechanism of pathology here? I think Dr. Esavias partly covered this.
Yeah, I stopped about the immunology, how the cytokine is released. I didn't go in deep because most of the people doesn't like immunology too much. But when the cytokine is released, the question is the mechanism of releasing of cytokines. So the question of Dr. Subramanian, how this cytokine can hurt the kidney, as I understand it. So the cytokine release, it's released by a T lymphocyte, B lymphocyte, and even antigen presenting cell like macrophage. And when they talk to each other, and they end up by releasing interleukin 1, interleukin 6, TNF alpha, and interferon gamma. This cytokine together, per se, can cause capillary vasodilatation and shock. This cytokine per se can activate complement. This cytokine per se can cause rhabdomyolysis. Or this a mechanism of this cytokine, of this mechanism, rhabdomyolysis, capillary vasodilatation and escape of fluids and shock and complement activation. All this, and also it can cause interstitial nephritis in the kidney and edema. All this will hurt, come together with the other factor and cause participate in acute kidney injury. And I said in the pyramid of the pathophysiology, kidney is a opposite organ, and if you have two injurious agents together, this is enough to cause acute kidney injury. And I have explained hemodynamic factor, angiotensin factor, cytokine factor, and direct invasion factor, and microthrombotic factor. All this, you have 5 major elements. If any two of them hit the kidney, is enough to cause acute kidney injury. Cytokine is one of them as a mechanism. The mechanism of release of cytokine, as I explained it, a stimulation of antigen presenting cell when it engulf the virus and presenting it with a major histocompatibility complex to the T cell receptor, and the T cell receptor get activated by signal 1, and then it activates the signal 2. Signal 2 will help releasing of the cytokine, will activate the antigen presenting cell itself, a macrophage or monocyte, to secrete cytokine, will activate through T helper cell. Once the T lymphocyte activated, one of the sub division of the T cell is T helper cell. It would activate also B lymphocyte to secrete more cytokine. B lymphocyte per se can be activated by the antigen itself called super antigen and secrete cytokine, and so on. It's like a whole vicious cascade together.
There is a question about TOSI in renal transplantation. I'm gonna give you my anecdotal experience. So one thing about transplant, first of all, you have to stop CellCept, and for patients who develop COVID, and then continue on the calcineurin inhibitor. We found that really Prograf has antiviral activity against COVID. It has been shown to be to have antiviral activity, and we've used actually tocilizumab in patients with kidney transplant, and I can tell you that after the first day they get better. So we have used it. We had no problem using tocilizumab in transplant patients, so there is no problem with that, at least based on our own experience.
There's a question on the use of cytosorb filters in patients with ARDS before they develop AKI, if they have high cytokine levels.
Yeah, and that's the study. The German study doesn't require really acute kidney injury to use the cytosorb. So it's really based on CRB and the requirement for pressure to actually, so you have CRB that is above 100 and patients is really in hypoxic and on pressor support, that's the requirement to be in the study. It has no requirement for enrollment to have acute kidney injury.
I have the same question in different way from Dr. Muhammad Nasser. Cytosorb filter versus IL-6 blockage in reducing the IL-6 level in severe COVID-19 with suspected cytokine storm. Shall we use CRRT for this reason only without evidence of AKI?
Right. So I think for us, I mean, as I said, the FDA already approved the cytosorb for emergent use. So if I have a patient that really I'm gonna use cytosorb and doesn't require CRRT, why I would do that instead of using one of the approved drugs for IL-6 inhibition or the IL-6 receptor inhibition, tocilizumab, because the other one is not approved yet. But so for me, I would use the cytosorb if the patient require acute kidney renal replacement therapy as a start, rather than just use it for everybody with high IL-6, because I have another drug to use and it's only one injection. You can repeat it in one day and that's it. And obviously, you don't have to have a central line to use a CRRT machine and to increase the risk of infection and all of the requirement to start patient on dialysis. So if we have this cytosorb approved, but we have the drug to use for IL-6 inhibition specifically, so why I would use cytosorb? So we haven't actually used the cytosorb as we speak as of today.
To summarize this, if I understood, so if the patient have an AKI, we'll go for cytosorb. If the patient doesn't have an AKI, we'll go for IL-6 tocilizumab.
Right, and it depends really on your availability. So if you have tocilizumab available to use right away, I mean, you have to think about really the requirement to start someone on CRRT and then add another dialyzer, which will add to the expense as well. But if you want to try it as a potential therapy, we don't have data on it yet. So that's the caveat. You have to think about data. We don't have great data apart from case reports.
So this will bring us to the previous question, which is saying, can we use a cytosorb before the patient develop AKI? In this case, we can use the anti-IL-6, that is
that's what I said. But what I'm saying is that the German study doesn't require AKI as a criteria to use the cytosorb. They actually testing the cytosorb in everybody, whether AKI or not.
Okay.
There's a question about the use of anticoagulants. Which is the preferred one, the low molecular weight heparin or unfractionated for patients who require CRRT?
Go ahead.
For patients who require CRRT, which
yeah,
is the anticoagulant?
We use heparin, really, because of the cost, obviously, and unless the patient has a contraindication to use heparin, we use heparin as primary anticoagulation unless it's contraindicated, and then we move to other forms of anticoagulation.
There's a question about patients on hemodialysis who are in end-stage renal disease. Most of the patients seem to be asymptomatic. Why is that?
We think that really it has to do with their immune response is not as good as a normal patient. So we think they are immunosuppressed. So it's like giving them anti-cytokine treatment. So they don't have the immune system doesn't have the ability to trigger a very strong immune response that is releasing all these cytokines that causes a lot of damage. So, and that's a speculation, by the way. It's not really proven yet, but we think that really the dialysis patients are immunosuppressed patients, and that therefore, and it's similar to our transplant patient, they did very well.
In acute lung injury, there has been a few studies showing the effectiveness of dexamethasone. Any studies on AKI? early use of dexamethasone preventing AKI?
Not in AKI. The only study from the UK that used dexamethasone, and again, it's really not for everybody. I think it's really another way of anti-inflammatory response. So meaning that those patients with high cytokine that you think that really is they're going to have a cytokine storm, dexamethasone may be helpful in that regard. But otherwise, I wouldn't use it universally on everybody.
The study published speak about those who have a lung injury and compare those who have no need for oxygen, need of oxygen or ventilated. So they found that it's beneficial for those who are in need of oxygen or ventilated, decrease mortality. While those who doesn't have a pulmonary involvement or pulmonary or doesn't have a or doesn't need the oxygen supply, which means their lung lesion is mild, use of dexamethasone doesn't help. Only those who have a lung lesion requiring oxygen or requiring ventilation. This is the outcome of the study. It decreased the mortality. But those who doesn't need oxygen, use of dexamethasone didn't help.
There's a question. He's asking, if I have a patient who is COVID positive on oxygen mask, he has evidence of proximal tubular dysfunction. How should he manage?
What do you mean by proximal tubular dysfunction? You know, did he measure all the urine and found there is glucosuria, amino aciduria, and phosphaturia to
Yes.
focus on.
Yes.
But as I said in the Wuhan data, as they compared the mortality for those who have hematuria, proteinuria, presence of hematuria or proteinuria per se can increase the mortality in those people, even if they don't have an AKI, yes. But to use the proteinuria and the hematuria as a marker to initiate renal replacement therapy, but there is no data about this. So it will become, unless Dr. Mohammed have something to say.
Yeah, if you think that your patient has proximal tubular injury with the loss of bicarb and phosphate in the urine, and you've proven that, one drug that can be helpful is really dipridamole, 75 milligram 4 times a day, if the patient can really tolerate it, and that really upregulates some of the transporters and the proximal tubules to reabsorb back the phosphorus and the bicarb. So that's one way of dealing with those patients.
Okay, I think we have come to the end of the questions. Any other comments?
No, I mean dipridamole 4 times a day will be will have an antiplatelet effect, which will enhance the anticoagulation. So it's good.
Yes. It was a wonderful talk, both of you, and we really learned a lot, new information.
We get a question. We get a question to Dr. Mohammed.
That's a new. Yeah, that's a new
Which
question.
mode of CRRT you use? Which mode of CRRT you use, Dr.
We don't use pre-filtration fluid or post-filtration fluid. We use the CVHD mode, which is really the regular mode without pre or post filter fluid, and again the intermittent mode if we need more machines to be working. Right now we are on the slowdown, at least in Maryland, on Northeast, at least the wave that we had in March and April has subsided, so we have enough machines now. So CVVHD is the mode that we use now. Thank you all for attending, and really appreciate it.
Thank you all for attending. Thank you, Professor Atta, for joining us from Baltimore.